Welcome to today's video lecture. Today, we're going to delve into a fascinating topic, rheumatic fever. Before we start, don't forget to check out our website madeformedical.com for hundreds of more videos like this at the end of this video. The link is in the description. Welcome to today's video lecture on sarcoidosis. In this session, we will delve into the intricacies of this complex disease, including its etiology, pathophysiology, clinical presentation, diagnostic approaches, and management strategies. By the end of this lecture, you will have a comprehensive understanding of sarcoidosis and its impact on patient care. So, let's begin. Sarcoidosis is a systemic inflammatory disease characterized by the formation of small clusters of cells called granulomas in various organs and tissues throughout the body. The exact cause of sarcoidosis is unknown, but it is believed to involve an abnormal immune response. The granulomas that develop in sarcoidosis are primarily composed of immune cells called macrophages. These granulomas can affect any organ or tissue in the body, but they most commonly involve the lungs, lymph nodes, skin, eyes, and liver. Sarcoidosis can vary widely in its presentation and severity, ranging from mild and asymptomatic cases to more severe and progressive forms of the disease. It is believed to result from an exaggerated immune response to certain triggers, such as infectious agents, environmental exposures, or genetic predisposition. The immune system reacts to these triggers by forming granulomas, which can lead to inflammation and tissue damage. The pathophysiology of sarcoidosis involves a complex interplay of immune system dysfunction, inflammation, and the formation of granulomas. While the exact cause of sarcoidosis is still not fully understood, several factors contribute to its development. Abnormal immune response. Sarcoidosis is believed to arise from an exaggerated immune response to certain triggers, such as infectious agents or environmental factors. It is thought that an initial exposure to these triggers in genetically susceptible individuals leads to an immune system activation. Granuloma formation. In sarcoidosis, activated immune cells, primarily macrophages, accumulate and cluster together to form granulomas. Granulomas are small, compact nodules consisting of immune cells, including lymphocytes, macrophages, and multinucleated giant cells. Inflammatory cytokines. In sarcoidosis, immune cells within the granulomas release various inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, interferon gamma, IFN gamma, and interleukins. These cytokines contribute to the ongoing inflammation and tissue damage seen in sarcoidosis. Tissue infiltration and damage. The granulomas can infiltrate and affect multiple organs and tissues, including the lungs, lymph nodes, skin, eyes, liver, and spleen. The presence of granulomas disrupts the normal architecture of the affected tissues, leading to tissue damage and dysfunction. Fibrosis. In some cases, sarcoidosis can progress to fibrosis, which is the excessive formation of scar tissue. The continued inflammation and tissue damage can lead to fibrotic changes, particularly in the lungs. Fibrosis can impair organ function and lead to respiratory symptoms and complications. Genetic factors. There is evidence suggesting a genetic predisposition to sarcoidosis, as the disease tends to cluster within families. Certain genetic variations related to immune system regulation and antigen processing have been identified as potential risk factors for developing sarcoidosis. Sarcoidosis is a systemic inflammatory disease that can affect multiple organs in the body, most commonly the lungs and lymph nodes. However, it can also involve other organs such as the skin, eyes, liver, heart, and nervous system. The clinical presentation of sarcoidosis can vary widely depending on the affected organs and the severity of the disease. Here are some common clinical manifestations. Pulmonary involvement. Sarcoidosis often affects the lungs, and pulmonary symptoms are present in the majority of cases. These may include a persistent dry cough, shortness of breath, chest pain, wheezing, and in advanced cases, pulmonary fibrosis. Lymph node enlargement. Enlarged lymph nodes, particularly in the chest and neck regions, are a common finding in sarcoidosis. These enlarged lymph nodes may be asymptomatic or cause discomfort, pain, or swelling. Skin involvement. Skin manifestations occur in about 1/3 of individuals with sarcoidosis. These can present as raised, reddish-purple bumps or patches on the skin, typically on the face, arms, legs, or buttocks. Other skin symptoms may include rashes, nodules, ulcers, or discoloration. Ocular symptoms. Sarcoidosis can affect the eyes, leading to various eye-related symptoms such as dryness, redness, blurred vision, eye pain, sensitivity to light, and in severe cases, uveitis or inflammation within the eye. Cardiac involvement. In some cases, sarcoidosis can affect the heart, leading to arrhythmias, heart failure, or conduction abnormalities. These cardiac manifestations may cause symptoms such as palpitations, chest pain, shortness of breath, or lightheadedness. The diagnosis of sarcoidosis involves a combination of clinical evaluation, medical history, imaging studies, laboratory tests, and sometimes tissue biopsy. Here are the common methods used to diagnose sarcoidosis. Clinical medical history and physical examination. Begin by taking a detailed medical history from the patient, focusing on their symptoms, onset, duration, and progression. Inquire about any respiratory symptoms, skin changes, eye problems, joint pain, fatigue, or other systemic manifestations. Ask about any potential triggers or exposures that may be relevant to sarcoidosis. Perform a thorough physical examination, paying attention to specific findings associated with sarcoidosis. Look for signs of skin involvement, e.g., erythema nodosum, lupus pernio, enlarged lymph nodes, respiratory abnormalities like crackles, wheezes, joint swelling, or other organ-specific symptoms. Laboratory testing. Laboratory tests are important to support the diagnosis of rheumatic fever. These may include blood tests. Perform a complete blood count, CBC, to assess for anemia or abnormal white blood cell counts. Measure inflammatory markers such as erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. Evaluate liver function tests, serum calcium levels, and vitamin D levels. Serum ACE level. Although not specific to sarcoidosis, elevated serum levels of angiotensin-converting enzyme, a CE, can be suggestive of the disease and may aid in the diagnosis. Tissue biopsy. In cases where the diagnosis remains uncertain or when tissue confirmation is necessary, a biopsy of an affected organ may be performed. Biopsy samples can be obtained from the skin, lung, lymph nodes, or other involved organs. The presence of non-casating granulomas on histopathological examination is a key feature of sarcoidosis. Exclusion of alternative diagnosis. Sarcoidosis is a diagnosis of exclusion, meaning that other possible causes of the patient's symptoms should be considered and excluded through appropriate investigations. The treatment of sarcoidosis depends on several factors, including the severity of the disease, the organs affected, and the individual patient's overall health. Treatment aims to reduce inflammation, manage symptoms, prevent complications, and improve quality of life. Here are most common treatment options for sarcoidosis. Non-steroidal anti-inflammatory drugs, NSAIDs. NSAIDs such as ibuprofen or naproxen may be used to help relieve pain, inflammation, and reduce fever associated with sarcoidosis. However, they do not directly treat the underlying disease process. Corticosteroids, such as prednisone, are commonly used to reduce inflammation in moderate to severe cases of sarcoidosis. They are effective in controlling symptoms and preventing organ damage. The dosage and duration of treatment depend on the severity and progression of the disease. Steroid-sparing medications, such as methotrexate or azathioprine, may also be used as an alternative or in combination with corticosteroids to minimize long-term steroid use. Immunosuppressive medications. In cases where corticosteroids alone are insufficient or not well tolerated, other immunosuppressive medications may be prescribed. These medications, such as methotrexate, azathioprine, mycophenolate mofetil, or anti-TNF agents, help suppress the immune response and reduce inflammation. Pulmonary rehabilitation. In cases where sarcoidosis affects the lungs and causes breathing difficulties, pulmonary rehabilitation programs may be recommended. These programs involve exercise training, breathing techniques, and education to improve lung function and overall physical well-being. Surgical interventions. In some cases, surgical interventions may be required for specific complications of sarcoidosis, such as removing enlarged lymph nodes or repairing organ damage. However, surgical interventions are relatively rare in sarcoidosis treatment. In conclusion, sarcoidosis is a complex and multifaceted disease that requires careful management and ongoing monitoring. By understanding its etiology, pathophysiology, clinical presentation, and treatment options, healthcare providers can provide optimal care to individuals affected by sarcoidosis. And that brings us to the end of our today's video. I hope you found the information helpful and informative. If you enjoyed this video, don't forget to give it a thumbs up, and don't forget to sign up for a premium membership on our website, madeformedical.com, for more content like this.